My topic is on brachial plexus injury. In order to understand brachial plexus injury, we need to understand the definition of the brachial plexus, which is the nerve network that sends messages down from the spinal cord down into the arm. Damage can be caused in several different ways. One of them is compression, another is stretching, and another is tearing off from the spinal cord. This can result in loss of sensation, loss of motor function, pain known as neuropathic pain, and shoulder contractures. Some causes of brachial plexus injury can be stingers, which happens frequently in contact sports such as football. These are usually pretty minor. It can also occur in injured infants during childbirth. However, this is pretty rare. It occurs in 0.9 to 2.3 in every 1,000 births. It can occur due to tumors or edema, as well as car or motorcycle accidents. And these are usually resulting in the most severe injuries. This is one of the most devastating injuries that can occur in the upper extremity, and psychological effects can occur that are related to body image. Also, there are effects of physical abilities. The physical abilities can include any tasks that require the use of the upper extremity. Now I'll go through the ICF categories that are affected due to brachial plexus injuries. This includes body structures, which would be the upper extremity. Body functions would be movements and sensations in the upper extremity. Activities and participation may include ADLs, IADLs, education, work, play, leisure, and social participation. Personal factors that could be affected would be very unique to the individual, but it could be values, beliefs, and spirituality. I'll provide you with an example to make this a little more clear. This could be a child who likes to hold a book in church while singing, and if they have sustained a brachial plexus injury that affects their ability to hold the book, this would affect some of the spiritual participation that they're used to doing. Environmental factors, again, are going to be very unique to the individual depending on their unique environment. However, home modifications, assisted devices, and equipment can help the person to function in his or her environment. So we're required to include some literature that relates to the ICF categories. So I'm going to elaborate on that a little bit here. Personal factors might include psychological effects, as I mentioned previously, and that was found in an article by McDonald and Pettigrew. Environmental factors can be affected, but adaptive equipment can help, as I mentioned. This can start out from very simple adaptive equipment to very complicated and high-tech adaptive equipment, such as a device that I found in an article called a customized exoskeleton-like device, and this was actually found to be pretty effective in getting the upper extremity to move properly and functionally. Another area of ICF that can be affected are both body functions as well as activities and participation. McDonald and Pettigrew pointed this out, explaining that the upper extremity deficits can involve sensation and movement of the upper extremity, and it can involve activities and participation in ADLs, school, work, and participation in the community. So the role of OT in brachial plexus injury. We are supposed to select appropriate evaluation assessments. We can treat anywhere from an infant up to an adult if need be. And if treating an infant, we want to start treatment as soon as possible. Therapy sessions are recommended at that age to be about 1 time a month or once every 6 weeks. Interventions that are implemented for really any age includes maintaining joint mobility, preventing contractures, providing sensory input, improving awareness of the limb that has been affected, and helping to facilitate normal development and normal function of the upper extremity. Some other treatment techniques might be using an orthosis or helping the individual to learn how to adapt their ADL and IDL activities. So as I mentioned previously, psychosocial factors can be pretty huge in this type of injury, and it can really affect the patient kind of like they have lost a limb. And McDonald and Pettigrew pointed this out in the literature, that we need to use our holistic healthcare approach to address the psychosocial factors that would affect our patients. Okay, so the assessment areas that need to be addressed. We do need to work with the infant and child and their family together. And we need to observe them completing tasks. And this can include a variety of tasks, but some examples are upper extremity range of motion, fine motor skills, ADLs, work and school occupations, leisure activities, participation in socialization, sensory motor skills, environment, and developmental milestones and reflexes. One of the assessments that I found in the literature is called computer adaptive tests. And essentially what it is a computer that assesses the accuracy of how the arm functions and how it is able to participate in activities. So it doesn't really directly assess the areas of development of a child, but the tests that are used in the computer adaptive tests do include some activities that could be comparable to some developmental milestones. And I provided some examples here, using an eraser without tearing the paper, opening up a can of soda, and cleaning a floor. Rationale for using this type of assessment would be that we want to assess the upper extremities functioning while completing activities in order to establish baseline information to build upon and refer back to during documentation. Another assessment that I found in the literature is called the active movement scale. This is essentially the scale that we use during manual muscle testing. It basically just measures how well the nerve is functioning through observing how the upper extremity muscles are functioning as far as strength goes. So it doesn't really directly assess an area of development either. This just assesses the muscle movement abilities and strength that can affect developmental milestones. Rationale for using this is that it evaluates the baseline range of motion and strength that help the OT to gauge how to challenge their patients. This also helps provide documentation to refer back to build on and demonstrate improvement in the patient's performance. So I wrote a therapy goal for a patient named Susie. Susie will demonstrate the ability to raise her hand 100% of the distance from a table to her mouth in order to complete self-feeding. She will achieve this during 6 out of 10 trials by July 1st, 2018. I chose 2 different frames of reference for intervention. One of them is the cognitive rehab frame of reference, and this one focuses on neuroplasticity. I did find some of this in the research. The research reports that retraining the brain to send information through the nerve is really important. This neuroplasticity concept is also used when training the arm to overcome non-use of the affected extremity. So this relates to Susie's goal by helping her to retrain both her arm and her brain to work together in order to complete the movement from her hand on the table to her mouth. The next frame of reference that I decided to use is the motor control or motor learning frame of reference. This focuses on just relearning movements that are skilled and voluntary. Some of the literature reported some similar information that training and relearning movements can help to improve all kinds of movements, but in this specific study, it did show significant improvement in upper extremity range of motion. This relates to Susie's goal because it helps her to relearn the skilled movement that is needed for bringing her hand to her mouth during self-feeding. I found 3 treatment activities in the literature: constraint-induced movement therapy, pulse electromagnetic therapy, and therapeutic taping. Constraint-induced movement therapy places a mitt on the unaffected extremity so it can't help the affected extremity. This is remedial and occupation-based. Susie would wear the mitt on her unaffected extremity so that she wouldn't help out her affected extremity during self-feeding. Pulse electromagnetic therapy stimulates the upper extremity nerves to improve muscle strength and range of motion. It's remedial and component-based, and Susie would use this to help innervate the muscles that are used for self-feeding. Therapeutic taping can stabilize the scapular joint. This is remedial and component-based. Susie could use this to help stabilize her shoulders so that she can use her hand functionally. So in conclusion, brachial plexus injury can be very devastating. However, OTs can help by facilitating increased movement, implementing compensatory strategies, and helping the patient to use adaptive equipment. Hopefully this would yield an overall improvement in quality of life.